I'll share it again. Can you all see my slides?
I sure can.
Okay, so it's my pleasure to talk to you today about PTSD, which is actually my expertise. I've worked with traumatized kids more than 20 years in my own country as well as here. I love this definition by Leonore Terr. She was one of the best child psychiatrists actually that inspired me years ago to work on this field. And she describes traumatic events and PTSD as the impact on children with how intense events they are. They are unusual, they are sudden, they really break past the child's ordinary coping and defense mechanism and rendering the child utterly helpless. That's the mechanism that any event, traumatic event, can make this child, affect the child starts. And trauma creates feelings of helplessness, vulnerability, loss of safety, control, intense fear, shame, and anger. I want to tell you, I'm sure most of you may have heard about this study, but this was a landmark study of adverse childhood events and how it impacts the health, mental and medical health of well-being of all the adults. And because of that, I think after this study came out, a lot of agencies and people really start to pay attention to early childhood trauma and events, and there were many things to follow this study. Finally, people are realizing the impact, which we know for many years. And in this study, they looked at these childhood adverse events. As you can see, child abuse, growing in domestic violence environments, living with mentally ill or addiction parents or parents who had discord or crime. So this was their database that they looked at all the Kaiser Permanente clients. And they found that.
I want to interrupt you for just a minute, Doctor. We're seeing your presentation view. Is there a way for you to flip it? So we're seeing both slides at the same time. If you can't, feel free to keep going. But for whatever reason, I thought we had it right. And then when you started talking, I see your future slides.
Sumru, if you just go to the top, you'll see a display settings drop down.
I can't see it in this one.
Okay.
This is all covering my screen, and here I see it on this side. Okay. Can you see it correct now?
No, nothing changed.
Okay.
Up at the top of the screen that I see, it does have display settings, and that would be where you would want to flip it. Do you see your, oh, now I just see you.
Yes, because I will share again because we fixed it and I don't know how it's changed again.
Hang on just a second, everybody. I think it would make for a better presentation if we could see the big slides. You're okay.
Can you see it?
Well, we're still back into there it is, right there.
Okay.
That's
all right. I was right here. Okay.
Perfect. Thank you so much.
Sorry for that. And they found in the study that the more ACE scores, the more traumatic events the clients, their study subjects have, the risk for all these increased dramatically. So they found that the more they had childhood or early trauma adverse events, they had self-injury, suicide attempts, addiction, sexual high-risk behaviors, repetitive trauma, of course, medical problems, as you can see, obesity, smoking, which actually, if you look at a pyramid of health, if we can help the adverse childhood events, childhood trauma and treat them, we can really prevent the disruption in the neurodevelopment because we know trauma impacts brain as well as epigenetic changes and social, emotional, cognitive impairment and risk behaviors. And this way, disease, disability, and early death. And they found that the life expectancy can decrease 20 years because of early childhood adverse events. And after this study, as you can see, that was a big impact on the new studies. Today, I want to talk to you briefly about what DSM-5 describes PTSD in children older than 6 years old. And the first criteria is they need to have an exposure to an actual or threatened death, injury, or violation in one or the following ways. And I really want you to think about threat of death, because for us as adults, threat of death can be very different than younger children. Younger children's perception and their threat of harm can be very low as threshold. So when we are hearing the stories of children talking about something they are very scared, we have to validate and we have to listen, looking at their age and how their perception is really the important aspect of being traumatized. They can be directly exposed to these events. They can witness in another person, like domestic violence. They can see it and they can be traumatized. They can learn about the events that happen to their family member, friend, or age mates, like school shootings. Even if it's not their school, they can be traumatized by hearing or seeing those things, watching those. And also the last one is for the adults who work with trauma, they can actually get PTSD. We need one intrusive symptom, which is, it could be distressing memories. However, in younger children, you will see it as play, repetitive play, which will be very different than normal play. In normal play, if you watch kids, they are really having fun, they are creative, they have positive affect. But in traumatic play, it will be very compulsive. There won't be much affect. And sometimes kids do it in a way that they can actually dissociate. So there's a very different quality of traumatic play, and they usually reenact what happened to them with their dolls or with the things or drawings. They can have distressing dreams, and it can be related to the original trauma, or it can be unrecognizable, but the theme is the same. It is somebody harming them or somebody scaring them. They can have dissociative reactions, but most young kids can freeze, they feel like they're not there, or they can act again during their traumatic play. They can dissociate, their mind is somewhere else while they are playing. They can have intensive psychological and physiological reactions when they see any clues about trauma. And younger children have a different way of building up their memory. So their really triggers can be very little things, like it could be just the resemblance of a person, it could be a beard, it could be a smell, it could be a sound, it could be a word. So these triggers can be ubiquitous that it may be hard to identify, and you can see suddenly kids are reacting, they are having a big anger outburst or crying or freezing or trying to hide under a table. So those can be their trauma triggers. They have a persistent avoidance is the second criteria cluster. Most kids with PTSD, traumatized, they avoid anything that will remind them the trauma. So they will avoid to go to places or see the people that are related to trauma, or they will try to avoid talking about it. They don't want to remember their memories, thoughts, or feelings. So if we do not ask about trauma, they are gonna never tell us, because they are trying to put it in deep down there and try to suppress it. So it's really important to screen children about trauma. If we ask them, if they are trusting us, they will be able to start disclosing what may have happened to them. This is very important. And that's why a lot of kids, unfortunately, when they are not screened, they can be misdiagnosed. This is a new addition to DSM-5, and I'm so happy to see that, because I have been seeing this clinically for many years. And especially this is for complex trauma. When kids have cumulative trauma, they start having alterations in their thinking, in their mood, and it can be many different ways. The first criteria is about dissociative amnesia. They may not remember all the aspects. They may have some memory problems, but the very important aspect of this is they start to have persistent, exaggerated negative thoughts, beliefs, expectations about themselves, the world, and others. For example, when you see traumatized kids, they will think that the world is a horrible place. Everybody's bad, or I am bad. So they will have these really core beliefs. And the next item is the same way. Their cognitions are so distorted, they really blame themselves about what happened, or sometimes they may blame others, but especially young children, as they are very self-focused, they blame themselves. And sometimes you find older kids, teenagers, they hate themselves. Where is that hate coming from? They may come from very early ages. And the other important criteria is persistent negative emotional state and unable to experience positive emotions. They are connected. Imagine children always feeling anxious, sad, and no emotions, and not being able to feel joy, happiness, fun, which balances normal kids, but their brain is so fixed in this negative state, they are unable to perceive positive emotions, and that affects, of course, their thoughts too, and their perception. And they will have diminished interest in activities. They isolate themselves because they won't trust anyone. So you can see how some of these are really similar to depression. And it's very common to have depression as a comorbid in PTSD. And the other criteria is high arousal and reactivity, which I think several young kids are misdiagnosed because of these criteria. If you look at them, they have irritable, angry outbursts, they are reckless, hypervigilant, they are startling all over the place, or they can't pay attention. Guess what? These kids commonly misdiagnosed by ADHD, because how can a kid be sitting in a classroom and listen when they are so scared that something's gonna bad happen any minute, that they have to be like watchful about what is going on? And that's very one of the common symptoms that they have. And also sleep disturbance, as we talked about, sleep is a big struggle with nightmares or falling asleep. And these symptoms have to be more than 1 month. They may have significant dissociative symptoms, we classify that way. And sometimes they don't have anything for 6 months. They may have a late onset. That could be possible too. I just want to tell you just a little bit about dissociation. This is one of our brain's coping mechanisms. We all have it. Even when we drive somewhere, we pass along many places, we don't even realize how we end up someplace, like our mind is somewhere else. But for kids, when they are having very painful, horrible experiences, intuitively, they dissociate. Their mind is somewhere else, like this body is experiencing this horrible pain, but they are not there. They watch themselves from outside. They feel they are in a dream or unreal state, and they lose time track. So this is how they dissociate. And if it's a chronic trauma, this dissociation can be a big part of their coping. So whenever there's a stressful event, if it's not traumatic, they may use that coping mechanisms and they dissociate. And many children show the sign, but they don't meet the full diagnostic criteria. You may see behaviors like this, or they can look like that they are hard to calm down, they have outbursts, they are regressive. When we say regressive, kids start to act like they are much younger. For example, an 8-10-year-old start to become anoretic, they start to pee in their bed, or they crawl under a table, they speak like a little kid. And as we talked about complex trauma, then what we mean by that, it's multiple interpersonal traumatic events from young age and recurring over period of time, so it's cumulative. And it, of course, affects, the biggest impact is everything from our brain impact to physical, emotional, social development. And it affects how they think about their cognitive, like think about themselves and the world. Also, I want you to remember neglect. It is perceived as a trauma by an infant or a young child who is completely dependent, and they feel helpless when their pain is not, when they're hungry, painful, cold, all those things, there's nobody to take care of them. I really love this painting. I just want you to look at it. When you look at it for the first time, you just see a big face. But then when you start to look at it, you see so many things. Like you see these really painful looking people, some monsters in the background. There are two guys and a horse, windmills, fire. There's like an angel there. This is like figuring out trauma, PTSD. You may see a lot of other disorders are easily, because when we just look at the symptoms, we can easily diagnose them. Oh, this is bipolar, this is ADHD or psychosis or personality disorder. But we really need to be able to look at, identify trauma and its impact, complex PTSD. We really need to take our time and take good history. These are common diagnoses given. You can really almost diagnose most of the DSM diagnosis for children because it's like chameleon. But when trauma is not asked, it has to be a very important piece to really accurately diagnose. And of course, they may sometimes have comorbidities too. I don't mean that when you have PTSD, you won't have anything. Actually, it's common that they may have depression and other mental disorders, substance addiction and other things can come on. And there are multiple treatments that we know, and many evidence-based treatments are coming out. I just put a couple of things, but first, psychoeducation. I really feel that parents, caregivers, foster parents, they really need to understand a traumatized child, why some of the kids are behaving the way they are, how they are coping. They need to be a part of the treatment and education because unfortunately, when you have all these kids acting out traumatized, the caregivers started to project on this kid that this is a bad kid. This is really very negative connotations, but they don't understand where this child is coming from and what these behaviors and emotions mean and how they can be also part of the team, treatment team, to really work together to identify triggers, what are the soothing things, and how to move forward with the treatment. And CBT is the trauma focus is one of the most studied evidence-based treatment, but also there are many studies coming with play therapy, trauma therapy, and also I give you this resource you may already know about National Child Traumatic Stress Network. They have multiple, they really review, they have a lot of resources for treatment, education, and event. And medications have some role, but we don't treat the PTSD symptoms, but comorbidities and sleep, those kind of things. And take-home messages really is, I want you to remember, children react to trauma in different ways. The younger, the longer, the worse impact. Trauma affects thoughts, behaviors, and emotional regulation. If you don't ask about it, you will not be able to find it. View the child's behavior through trauma lens and refer children for trauma treatment as early as you can, because we know that the effects of trauma will already start making changes. And this is some web resources at the end, and I highlighted the National Child Traumatic Stress Network. There are a couple others. So this is all. I'm open to questions. I think I gave you a couple of minutes.